Now that we've covered the pathology of red blood cells, platelets, and the coagulation system, we move on to the last major section of hemonc, and one of the most heavily tested, hematologic neoplasms. I want to start by making a quick distinction between leukemias and lymphomas. Leukemias are neoplasms of the bone marrow and are usually extensively involved in the bone marrow while having some circulating neoplastic cells, while lymphomas are discrete neoplasms of the lymphoid tissue. Unfortunately, it is possible for leukemias to end up in the lymphoid tissue, and for lymphomas to be bloodborne. But in terms of pathogenesis, we generally name these based on where they are most likely to arise from, and the major difference is in the starting point. In early diagnoses, and on your exams, it is important to know that a leukemoid reaction can look a lot like a leukemia. A leukemoid reaction is basically a leukocytosis with a left shift that is caused by acute stressors like a serious infection such as pertussis. Both leukemoid reaction and leukemias have increased WBCs, increased neutrophils, and increased neutrophil precursors like band cells, which is specifically known as a left shift. This is known as a left shift because in the early days when they used to record all these counts on paper, the bands were on the far left of the page, and when a patient had a bandemia, the count would shift to the left of the page, and they would call that a left shift. So how can we distinguish a leukemoid reaction from a leukemia? Well, basically, we want to check and see if the leukocytes are actually functioning to fight infections, or just multiplying like crazy in a cancer and not actually functioning. So we check for leukocyte alkaline phosphatase, which is high when the cells are working hard to fight off an infection, but low in a leukemia, where the cells are not actually working to fight infection. Now, actual lymphomas are classified either as Hodgkin or non-Hodgkin. Knowing the distinguishing features will help you make the diagnosis because this topic is very likely to show up on your exam. So what are the major features of Hodgkin lymphoma? You will have Reed-Sternberg cells, infamously known as owl's eye cells, that you will see on the histology slides. These cells can also be identified by flow cytometry with the cluster of differentiation markers CD30 and CD15. Additionally, a patient with Hodgkin lymphoma will usually have involvement of a localized single group of lymph nodes with contiguous spread. By contrast, patients with non-Hodgkin lymphoma will usually have involvement of multiple peripheral nodes with a non-contiguous spread. So if I said a patient had involvement in the nodes of the axilla, inguinal, and cervical chains simultaneously, sometimes with extranodal involvement, would that be Hodgkin or non-Hodgkin? That would be non-Hodgkin lymphoma. Patients with Hodgkin lymphoma will also have the constitutional 6 symptoms, also called the B symptoms, because A symptoms indicate an absence of infection. B symptoms include low-grade fever, night sweats, and weight loss. It is thought that about 50% of these Hodgkin cases are associated with EBV, or Epstein's-Barr virus, and Hodgkin's tends to affect the old or young in a bimodal distribution. There are a number of histologic subtypes within Hodgkin's, all of them being more common in men, except the nodular sclerosing type, which demonstrates a far closer 50-50 distribution among males and females. Importantly, nodular sclerosing is also the most common type. In addition to being the most common, nodular sclerosing has the best prognosis in Hodgkin lymphoma, with lymphocyte depleted or mixed having a poor prognosis. So what about non-Hodgkin? Well, non-Hodgkin does not have Reed-Sternberg cells and is often associated with HIV infection and autoimmune diseases. The peak incidence for certain subtypes is young adulthood, 20 to 40 years of age. Non-Hodgkin has a poorer prognosis than does Hodgkin disease. A USMLE favorite is to present a vignette and show a picture like this one, asking either the diagnosis or some feature of the diagnosis. Do you see the cell in question? This is an example of the Reed-Sternberg cell. If you see these cells, definitely think Hodgkin lymphoma. Conversely, if you think the diagnosis is Hodgkin lymphoma, and you are asked what cells you would expect to find, well then you'd pick the owl's eye cells. The distinctive bilobed, or binucleate nature of the Reed-Sternberg cell keeps the nuclei very close together, and gives it appearance of owl's eyes staring at you. Unfortunately, there are two other cells that could fool you into thinking that you're seeing the owl's eyes. Can you think of what those cells might be? Giardia and CMV infected cells both have a similar appearance, and especially the bilobed appearance of the CMV cell could be particularly confusing. As a review, name the cluster of differentiation markers that are associated with the Reed-Sternberg cells. That would be CD30 and CD15. So on your exam, if the STEM says that flow cytometry has examined CD30 and CD15 B cells, this is a clear giveaway for the Reed-Sternberg cells in Hodgkin's lymphoma. Be sure to know this association as it is likely to be tested. Next, we'll sort out the different types of non-Hodgkin lymphomas. It is helpful to differentiate them first as either B or T cell lymphomas. Unfortunately, many of the translocations that are associated with this disease are commonly tested in this subject and therefore are very high yield. So whatever memory tools you can use, like working with flashcards or call and response with a study partner, would probably be well worth your time. Starting with the B-cell lymphomas, we come to Burkitt's lymphoma, and there are a couple of points to highlight in this disease. First, Burkitt lymphoma has a very distinct starry sky appearance, as seen on this H&E stain. The dark part of the sky, or the purple background here, is made up of hundreds of cancerous lymphocytes. These cells have an extremely high turnover rate and leave a lot of apoptotic cell debris behind. These cancerous lymphocytes are then interspersed with stars. These stars, in reality, are macrophages that have been gorging themselves on this apoptotic cell debris. Upon staining and fixing, the cytoplasm of these macrophages shrivel up and become the white spaces in the dark background. This appears to be stars in the night sky, hence the name starry sky appearance. The most common cytogenetic abnormality associated with Burkitt's lymphoma is a chromosome 814 translocation, which causes the c-MYC gene to move from its natural regulation site to the regulation site of the heavy chain Ig gene. From pathology, do you remember what the c-MYC gene does? As it turns out, it's a transcription factor, and importantly a transcription factor that happens to greatly upregulate cell division. The important point is that c-MYC has been taken out of its natural regulation site on chromosome 8 and placed somewhere that it gets transcribed constantly, like under the regulation site of a heavy chain Ig site in a B cell. So now we have way too much transcription factor just floating around and causing all sorts of crazy cell division. The c-MYC gene itself is originally on chromosome 8, so less common translocations can be responsible for Burkitt's, but importantly, these must also involve chromosome 8 in some way. Less common translocations would be 822 and 28 translocations. Sometimes the boards do test these less common translocations, so don't assume that just because it's not 814 that it can't be Burkitt's. For your exam, you should be aware that in Africa, there are endemic regions where Burkitt's lymphoma is caused by the Epstein-Barr virus infection, and this endemic form of Burkitt's leads to a characteristic jaw lesion that is a commonly tested point. Despite the common picture of a small child in Africa with a prominent jaw lesion, the majority of patients in America who suffer from Burkitt's are adolescents or young adults with the sporadic form. This sporadic form commonly has involvement of the abdomen or pelvis. The second B-cell non-Hodgkin lymphoma we will discuss is also the most common type of non-Hodgkin lymphoma, diffuse large B-cell lymphoma. This usually occurs in older adults, but it can also occur in children. There is an association between translocation 14-18, however we will see this more commonly next. Although the name tells you that this is usually a B-cell neoplasm, there are unfortunately forms that can be T-cell in origin. Follicular lymphoma is next, and it carries a chromosome 14-18 translocation that increases the expression of BCL2. In another throwback to pathology, do you remember what the BCL2 gene does? Well, this is an anti-apoptotic molecule, so when it is upregulated, cells become basically immortal. Follicular lymphoma presents with the classic waxing and waning lymphadenopathy. The next B-cell non-Hodgkin lymphoma is mantle cell lymphoma. Mantle cells are CD5 positive and carry a chromosome 1114 translocation. Mantle cell lymphoma is the result of an overexpression of cyclin D1. Remember that both mantle cell and follicular lymphomas are relatively indolent, meaning that they are slow-growing cancers, and they are unlikely to lead to a rapid death. In contrast, Burkitt's and diffuse large B-cell lymphomas are both rapidly dividing cancers. Transitioning to the mature T-cell lymphomas, adult T-cell lymphoma is caused by the human T lymphotropic virus and is a particularly aggressive lymphoma, and patients will present with cutaneous lesions. Adult T-cell lymphoma is also associated with IV drug abuse. Mycosis fungoides, or Sézary syndrome, used to be thought of as a fungal infection, but is now recognized to be a cutaneous T-cell lymphoma. Patients also present with cutaneous plaques, patches, and nodules with the potential to spread to lymph nodes and viscera. Since these are T cells, what would you expect to see by flow cytometry? Well, you might expect to see CD4 positive cells. Also, in contrast to adult T-cell lymphoma, mycosis fungoides is a relatively indolent lymphoma. Notice that in contrast to mature B-cell lymphomas, the mature T-cell lymphomas feature prominent involvement of the skin. In this image, you can see the characteristic crowding of plasma cells in multiple myeloma. You should be able to recognize plasma cells based on their high nucleus to cytoplasm ratio, the eccentric nucleus, and the dark purple heterochromatin that looks kind of like it forms the numbers on the face of a clock. Multiple myeloma is the most common primary bone tumor in the elderly. The clinical picture of a patient with multiple myeloma can be remembered with the mnemonic CRAB. C stands for hypercalcemia that spills into the blood with the destructive bone lesions. The R stands for renal insufficiency, and along with this, you'll also find the classic Bence-Jones protein in the urine, which are really monoclonal immunoglobulin light chains that are produced by the neoplastic plasma cells and that eventually spill into the urine. A stands for anemia, secondary to the bone marrow being overtaken by tumor cells, and B stands for bone or back pain, associated with the pathologic breaks in lytic bone lesions. Other interesting features of multiple myeloma include a peripheral smear, which usually shows rouleau formation. Rouleau formation literally looks like RBCs stacked up in a poker chip formation. With all of these proteins causing the RBCs to stick to one another, as we see in this photo, is there another lab test that we've talked about previously that would be abnormal in this patient? Well, RBCs sticking to one another is the definition of how we increase our ESR, so the ESR would be elevated here. Multiple myeloma patients also have an increased susceptibility to infection because although we have all these antibody products floating around, we aren't making the antibodies that are actually focused on fighting infections. What secondary condition could be caused by all of these proteins now found in the bloodstream that will eventually settle into other tissues? That would be primary amyloidosis. In this plain film of the skull, you can clearly make out lytic lesions in a patient that suffers from multiple myeloma. It looks like chunks of the bone have been punched out, so these sometimes may also be referred to as punched out lesions. In thinking about multiple myeloma, diagnosis is usually made by performing either a protein electrophoresis of the urine or of the serum. These are known as a UPEP or an SPEP. In this drawing of a normal SPEP, we can see a normal albumin spike, as well as two alpha spikes, a beta spike, and a normal broad gamma spike. However, in a multiple myeloma patient, instead of having a normal gamma spike with a variety of immunoglobulins creating a wide hump, there is a single, large, narrow spike called an M spike, which represents an overabundance of monoclonal antibodies. And just to be clear, it's called an M spike either because of how the tracing looks, kind of like an M, or because they are monoclonal antibodies. Importantly, however, these are typically not IgM antibodies. In fact, this M spike on the SPEP is usually made up of IgG proteins, and can also be IgA proteins. Can you think of another cancer of B cells that will show an M spike on SPEP? That's Waldenstrom's macroglobulinemia. And importantly, this M spike is made of IgM proteins. These patients will present with serum hyperviscosity symptoms like mucous membrane bleeds, headaches, visual changes, seizures, and strokes or comas due to an increased viscosity of their blood from all the extra protein. In contrast, patients with Waldenstrom's macroglobulinemia will not have lytic bone lesions on their X-ray. If the macroglobulinemia is diagnosed by SPEP, but the patient is asymptomatic, it is classified as MGUS, or monoclonal gammopathy of undetermined significance. As expected from the name, this condition involves monoclonal plasma cell expansion without the symptoms of multiple myeloma. While MGUS itself is not dangerous, it does carry an increased risk of multiple myeloma conversion for every additional year that you carry the diagnosis of MGUS. Here's a quick flash quiz for us. The most common type of non-Hodgkin's lymphoma is a B or T cell lymphoma. Well, this most common type is the diffuse large B-cell lymphoma, which is most commonly a B-cell lymphoma. Myelodysplastic syndromes are stem cell disorders that involve defective cell maturation in all cell lines that are not lymphoid, and these are caused by environmental exposure like radiation or chemotherapy. These diseases may transform into AML, but the pathognomonic sign here is the pseudo-Pleasure-Hewitt anomaly, which are neutrophils with bilobed nuclei connected by a thin chromatin filament. These are often seen after chemotherapy.